Okay, good evening. Welcome everyone. I'm Lauren Gueits, along with my co-host, Dr. Ben Miraglia. We have a very special Airway Health Solutions conversation featuring Dr. Jerald Simmons. We have an exciting topic tonight. It's bruxism and airway, and we certainly had a lot of questions, which I know Dr. Simmons will answer throughout this session today. So let me tell you a little bit about Dr. Simmons. Dr. Simmons is the founding director of the Sleep Education Consortium and Comprehensive Sleep Medicine Associates. He is triple board certified in neurology, epilepsy, and sleep medicine. He's a graduate of Ohio State University. He trained in neurology at Washington University, sleep medicine at Stanford University, and epilepsy at University of California. He began his professional career as assistant professor of neurology at UCLA while co-directing the UCLA Sleep Disorder Center and directing the clinical neurophysiology lab, thank you, at Olive View, UCLA. His most recent research involves the relationship between quenching sleep bruxism, TMJ disorder, and obstructive sleep apnea, as well as the relationship between ADHD and disturbances of sleep. He has been instrumental in providing guidance to the Texas State Board of Dental Examiners that led to the new rules requiring dentists to obtain some degree of education in sleep medicine in order to provide appliance therapy to patients with obstructive sleep apnea. Most recently, he is the head of the ADA task force for screening pediatric patients for sleep apnea. So I know it took a while to welcome you because you have a lot of credentials, but welcome, and we are so thrilled to have you here, Dr. Simmons. Thank you.
Thank you. It's my pleasure to be here.
Great. And I am going to actually turn the mic over, the hosting job over to Dr. Miraglia, because I know he's dying to ask you a few questions and get to know a little bit more about your background in dental and medicine.
Great.
Yeah, welcome, Dr. Simmons, and thank you very much for joining us.
Thank you.
So I know that Lauren just read a pretty comprehensive bio, but is there anything about your background that you'd like to share a little more with us?
Well, just that, it's unusual for a physician, and years ago, I was sort of looked at a little bit oddly from some of my peers that, I recognize the role that dentists can actually play in the field of sleep medicine. While I was on faculty at UCLA, I actually submitted a grant to the NIH. It was a sleep education grant where we talked about enhancing the educational system in medical school. And the grant did not get funded. And half the reviewers thought I was a genius, and half the reviewers thought I was a totally misguided physician and I shouldn't think so much about dentistry. And that was back in the 90s. But I realized that the jaw, the teeth, and the airway, how it's not a stable part of the anatomy, and it modulates throughout the night. And the dentists, their job is to look in everybody's mouth. And if they just knew what they were observing and the relevance, then we could be able to identify sleep disordered breathing in quite a few patients that are currently being missed that have this kind of problem.
Well, we really appreciate you recognizing the dentists, and we've got a bunch of them on there tonight listening to you. I'm going to throw a question at you, which will probably be more leading into what you're about to share, but let me run this by you. And if it's something to answer now or just to get into your presentation, I'll let you decide. But I'm interested in sharing, what measurements are made during a sleep study that will provide information about bruxism, and how are you able to demonstrate a relationship between bruxism and airway obstruction? Now, part two, a follow-up would be, how does it relate to negative pressure in the airway? I know that's a piece of the puzzle.
Right. Well, Ben, thank you. Great. Okay, that is a good segue because, let me do this. Let me share my screen, and we'll go from there. Let me see here. I'm gonna make sure you're able to see here. Can you?
Yep.
Okay, you see this? Okay, there's my introductory slide there. Pass that up. Okay, so what's real important? You said what measurements? What's really important is that not all sleep testing is the same. There are different types of sleep studies, and they're categorized as type 1 through type 4. But here, I'm going to get a little laser pointer. Can you see my little laser pointer on there?
Yeah.
Good. Okay. Well, in-lab polysomnography is pretty much type 1, but a lot of dentists are using type 3 and 4 devices. These are not going to provide you the type of information that a type 1 study is going to provide. And we're going to go over that in just a second. But so what measurements are being made to show the association? I'll give you some examples of that. But what's real important is that a dentist or anyone dealing with patients that has sleep problems have to realize that sending someone home on a little sleep recording device is not necessarily going to tell you everything that there is. So if it comes back negative, it does not mean the person does not have a sleep problem. That's my biggest concern, is a negative home sleep test, because sometimes it stops right there, and it shouldn't. If someone has clinical symptoms, trust your gut, trust your medical decision-making, and don't base it all on a negative home sleep test. Okay, so let's talk about the negative pressure, all right? Well, when we breathe, air rushes to the back of our throat, and as air flows through the back of the throat, it creates a negative pressure. It's called the Bernoulli effect. The example I like to give of the Bernoulli effect is in the showers. You know, when you turn on the shower, you know, as the water flows, how the shower curtain can pull in towards the water? That curtain is pulling in because of the vacuum that's created from the flow. The amount of pressure or negative pressure, the vacuum, that's going to be developed depends on how much space there is for that flow to occur through. So if you have a smaller space, you get a stronger vacuum. If you open up the space, there's less of a vacuum. So, you know, the shower curtains that bow outward, they open up the space and it prevents the curtain from pulling in, all right? Same principles occur in the back of your throat. So when you're breathing a negative, and as you get a vacuum here, that vacuum will start pulling in on the tissue, all right? And if everything starts to collapse, you now have a more narrow airway, and now it's a stronger vacuum, and the tissue will start to vibrate. That vibration is snoring, all right? So snoring alone tells you that there's negative pressure in the back of the airway. And at a certain point, the vacuum is so strong that the airway will completely collapse. And at that point, a person's trying to breathe, but they can't. And then the brain says, hey, wake up. And there's a brief awakening, the airway opens up, and the breathing starts up again. That's classic obstructive sleep apnea. But there are a lot of patients who only have a partial blockage. So they're creating more negative pressure, and they're still getting air. And the brain realizes that the person's working harder to breathe. And because you're working harder to breathe, that creates a stimulus to have a brief awakening, and the airway opens up. So it's not about oxygen. I'll say it again. It's not about oxygen. This is not called desaturation apnea. It's called obstructive apnea because there's airway obstruction. And the common denominator is the obstruction, not the oxygen. All right. So you do not need to drop your oxygen at all. And you could still have clinically significant obstructive sleep apnea. So if you look at an in-lab sleep study, a polysomnography study, there's all these parameters: brain waves, eye movement channels, muscle activity from the face, the EKG, leg movements, snoring from microphone, airflow through the nose and mouth, movement of the chest, movement of the abdomen, and then there's oxygen levels. Those are the typical standard parameters, okay? And this is 2 minutes that we're looking at. And this is classic sleep apnea where the person's not moving air. You see how it's a flat line, but yet they're trying to breathe and the oxygen drops. That's classic. All right. Now that negative pressure is not just in the back of your airway, it disseminates to your whole chest. So when you start getting obstruction of the upper airway because things are collapsing, that increased negative pressure disseminates into your whole chest. So your chest becomes like a vacuum chamber. I don't have time to go into all the ramifications of all that, but what's important to, again, point out is it's a pressure problem, okay? So now if you were to put a probe down someone's nose into their esophagus to measure that negative pressure, this is what you would see. Here's the sleep apnea right here. The person's trying to breathe, all right? And look at what you can see, the increased effort with each breath. That increased effort, that's a catheter that's down in the esophagus that's measuring the vacuum. Look at the crescendo increase. Finally, the person's working so hard that they wake up. With the awakening, the airway opens up, and now they don't pull so hard to breathe because they're awake and the airway is open. So this negative pressure is the main signature of obstructive breathing during sleep, obstructive sleep apnea. All right, here it is occurring over and over again, repetitively. This is just 2 minutes on the screen. So this is half the screen right here. See one apnea, there's a brief awakening, the airway opens up, and they go right back to sleep. They're having another apnea. So I want you to see the increased effort that goes into the leading to the arousal. All right. And this is a hypopnea. Hypopnea means that there's a partial blockage. There's still airflow, but it's not normal airflow. So you see the person's working hard. There's a reduction of flow right here, and it leads to an arousal. If you had a catheter in them, you'd see the same signature of the crescendo increase in effort leading to the arousal, right? That crescendo increase in effort, okay? You've heard of the upper airway resistance syndrome. Some of you may not have heard of that, but that's a condition where the person's having respiratory events that do not qualify as hypopneas, but they're still causing arousals. They also have this crescendo increase in effort leading to the arousal, right? And they have these respiratory effort-related arousals. This is the effort, right? Increased respiratory effort leading to arousals, okay? So in some patients, we will put a little catheter in the patient's nose. We have them drink water through a straw. As they sip on the water, we slide a little catheter and they swallow it. And that catheter measures the negative pressure. So Ben, your question was, what parameters do we look at to show the association, and what does it have to do with negative pressure? So I'm gearing that up so you guys understand that. Here's a polysomnogram, a pretty typical one. This person has a mild drop in the amount of flow, and they have a crescendo increase in effort that we're measuring with the catheter, and here's an arousal. Oxygen does not change at all. Running at like 95% SaO2, does not change, all right? And yet they're having a hypopnea with this reduced flow leading to an arousal. So you do not need to drop your oxygen in order to have a hypopnea. Medicare doesn't recognize that. That's part of the confusion, is that there are different people that will score things differently, and there are actually, I don't have time to go into this now. There's 2 scoring rules that are out there, both recognized, but the recommended rule is the one that says that you just have to have an arousal or a 3% desaturation, but in order to have hypopnea. The older rule says you have to have a 4% desaturation. Medicare recognizes the older rule; they don't recognize the newer rule. Not all sleep labs will score based on the newer rule. So just because you send your patient to a sleep lab, don't assume that it's the same no matter where you send your patient. A lot of labs still stick to the older rule, and they're looking for the oxygen to drop, okay? Here's another example. Oxygen does not drop. Crescendo increase in effort leading to the arousal, okay? All right, so now I talked to you about some of the physiology and the negative pressure, okay? But what's making it change? What are some of the variables? Well, the joint of your airway is right here, your temporomandibular joint. That's a valve. So based on where your mandible is positioned will influence the airway dynamics in the back of the throat, all right? So when you're in an occlusive relation, biting down in your TMJ, you're in an occlusive relation, that's a lot different than if you're in a centric relation with the most retruded position of your mandible in a centric relation, right? Because when you have your jaw falling back, your airway starts to obstruct. So if you remember, the genial glossus muscle is attaching to the inner aspect here of the mandible. So as your mandible goes back, the airway becomes more narrow, all right? So now, interesting, and I'm going to go in this a little more detail. If you were to measure the negative pressure, all right, if you were to measure the EMG, the muscle activity of your tongue, all right, and you then change the amount of negative pressure in your airway, you're going to see that there's going to be increased EMG activity, increased muscle activity as you develop more negative pressure. And I'll show this in a greater example, but this is a normal reflex that you maintain when you're awake. So if I'm breathing through a tube and now I breathe through a smaller tube, I now am going to have more negative pressure to breathe to get the same amount of air. And that increased negative pressure is going to stimulate my tongue muscle to increase the muscle tone. Now that reflex is maintained when you're in non-REM sleep. When you go into REM sleep, you lose that reflex, okay? When you if you drink alcohol before you go to sleep, you'll blunt that reflex. And if you're sleep deprived, you will blunt that reflex. So this reflex can be influenced. But this is a preservation reflex. Your increased muscle tone helps prevent the collapse in an environment with increased negative pressure. I'm going to show you another study that really exemplifies this. But again, here, when your normal airway and you posterior part of the pharynx And then when you fall asleep and the mandible falls back, the space becomes more narrow, there's more negative pressure, the tissue vibrates, you can get snoring, depends on how much tissue you have. So if you have a little bit of tissue, there may not be much snoring, okay? If you have a lot of tissue, you'll start snoring at lower amounts of negative pressure. So the absence or presence of snoring is not always the main feature that you're looking for. A person does not have to snore. They could still have a lot of obstruction. They just may not have a lot of redundant tissue to vibrate. So that's why you don't see the snoring, okay? But with this going on, there could be tongue thrusting. Tongue thrusting is a preventive measure. It's a preservation measure because it helps to open up open up the airway. So a lot of kids that are tongue thrusting, maybe they're doing that because their tonsils are enlarged, their airway's crowded, they're trying to breathe better, okay? So what about bruxing? How do you define bruxing? Some people think that, it's a grinding of your teeth. Well, that's not really true. It's a grinding or clenching, okay? The American Academy of Oral-Facial Pain will define it as a clenching or grinding, okay? It's not just a grinding. Clenching falls under the bruxing definition. American Sleep Disorders Association, same thing. And if you look at glossary of terms by the prosthodontic literature, they will have clenching also as part of the definition of bruxing. All right, so bruxing, right? So when we're talking about it, we got to make sure what we're talking about. It's not just a grinding; it's also clenching. Both of which will help bring the mandible more forward, or help at least prevent it from falling back. You don't grind your teeth with your mandible protruded. You'll grind it when you're almost in when you're almost in an occlusive relation, right? You're bringing your teeth together and you're grinding. So it will have airway improvements just like the clenching will, so the grinding will itself. So, okay. So think of sleep bruxism and tongue thrusting as neurologic reflexes that provide protection of the upper airway to help fight against the increased negative pressure that's developing, right? It's easy for me to say, but like what kind of examples? How do we know that that's really true? Well, when we look at patients, I as a neurologist will look at teeth. And when I see teeth like these, I know that the patient's bruxing in their sleep, right? And, and I'll do a sleep study and I'll see that, yeah, the person has has sleep apnea. But why is someone grinding so much and clenching in their sleep? Now, a lot of these patients, they're not clenching at all during the day. They're not bruxing during the day. They're bruxing in their sleep. And we can talk more about that whole natural progression and then taking history on this later. But, why is it that what's going on in sleep that's causing someone to brux? Stress, emotional stress, that's something you get during the day when you're at work. But when you're asleep and you're removed from all that, why are people tend to have more of their bruxing at that point in night, that point of the 24-hour cycle? Anyhow, there's more literature coming out about this. A recent article that came out a few years back talking about that tooth wear can be used as a sign of obstructive sleep apnea. Not news to me. Glad that it's finally getting out there in the literature. All right, but other literature that's very interesting is talking about adenoid and tonsillectomy and the occurrence of bruxism. There are several studies out there. Because of time, I'm just showing you this one where they basically looked at the occurrence of sleep bruxing in kids before they had their tonsils out, and it went from 25% down to 7% of the kids were bruxing after they got their tonsils out. So why is there improvement? Well, because the tonsils are adding to obstruction of the airway. Remove the obstruction, then you're not going to be bruxing as much. But that really doesn't answer the question. If these kids are having sleep apnea, maybe the bruxing is actually part of the arousal. It's in response to the apnea. How do we know that it's protecting the airway? Well, I'm going to point to you a really interesting study. All right, this study was done on patients that had tracheostomies. So they were breathing through their trach, and then they plugged the trach and they looked at the changes that were occurring in the airway. Okay, so just so you see here, this is a patient and they have a trach. The trach is open. So when they're breathing, the air is not going through their upper airway. The air is going through the trach. And they put a sensor here to measure the negative pressure here in the back of the pharynx, right? And over here in the nasal pharynx. And they measured flow. There was no flow. And they also put an electrode to measure the EMG in the tongue. All right. And they could see as a person was breathing, there were these little bursts of EMG activity. So the tongue was actually having a little bit of oscillatory increases in activity that were synchronized with respiration. Okay. So your tongue is hooked up to your brain, and as you breathe, it has slight increases in activity. But then they did something interesting. Okay, just to go back into that, again, I don't have much time, but the upper airway is controlled, the motor control of the upper airway is primarily through the hypoglossal motor nucleus. And that motor nucleus is going to control your tongue, your genioglossus muscle, and other upper airway muscles. There's rhythmic generators that are giving influence, and that's causing these little blips right here. But there's another part of the influence of the muscle tone, which is the negative pressure reflex circuit. Negative pressure in the upper airway that's now going to influence the amount of muscle tone, right? So they took these patients that were breathing through the trach and they plugged the trach. So by plugging the trach, air now went through the upper airway, all right? And they could see that here's flow being measured at the nose, and they can see that there's negative pressure with the breathing in both in the posterior pharynx and the nasal pharynx. But look at the EMG activity. It's augmented, it's increased. There's more negative pressure occurring here. Sorry, there's more EMG occurring here, more muscle activity with the influence of flow. So when you put these side by side, this is with the trach open and there's no airflow going through the upper airway. And when you plug the trach, now you get this augmentation of muscle tone, right? So this is showing you that the negative pressure in the upper airway will increase muscle tone of the genioglossus muscle. Okay, great. That's genioglossus muscle. What about other muscles? All right. So what about the masseter? The masseter is not thought of as being a respiratory muscle. Well, if you're clenching, you're bringing your jaw forward and it's going to help open up your airway. But does it change based on negative pressure? So there was a study that was done by Hollowell and Surratt. Really interesting study. They basically had individuals breathing through a tube, not like this, but breathing through another type of tube, and they changed the setting of this tube. There's a valve, and they basically can set it to how much negative pressure how much of a suction did you need to create to get the air to flow through, and they set it to different degrees of negative pressure. So they said that you had to pull negative 10 centimeters, then they set it to where you had to pull negative 20, 30, all the way up to negative 60 centimeters of water pressure. They simultaneously measured the EMG of the masseter and other upper airway muscles, all right? And even muscles of like the ala nasi, the dilators of the nose. And what they found is that as the amount of negative pressure was increased, the amount of muscle tone increased as well. So there was increased muscle tone in response to the amount of negative pressure that had to be exerted in order to provide respiration. So that's basically their conclusion, is that the masseter activation is going to be influenced by airway resistance and amount of negative pressure in the upper airway. And they found a similar response to other pharyngeal dilators. Okay, so this is information that is just out there looking at just specifically in a controlled scenario of what's going on with bruxing and airway dynamics and negative pressure. So years ago, I recognized this association, and because I was treating patients that were bruxers, I treated them for their sleep apnea, and their bruxing and their TMJ went away, and a lot of them threw away their bite splints. And so my professional path crossed with Dr. Ron Preen, who at the time was just an oral facial pain specialist, and he became a great friend, and we collaborated for many years. We still collaborate. He's actually also on the board for the Sleep Education Consortium. I got him introduced into dental sleep medicine, and he really did a tremendous job over the years in dental sleep medicine. He's actually was the president of the American Academy of Dental Sleep Medicine's board exam. So the board exam that the dentists take, it was Ron Preen's the president of. But Ron would send me when I told him this whole concept of bruxing and sleep apnea, he was intrigued, and he sent me more and more complicated cases that had more and more subtle degrees of obstruction that never would have made it to a sleep lab, because no one would have ever thought of sleep apnea as being part of the issue. And as time went on, we started recognizing, more and more success, and we started tabulating it. And basically, we found that we can, first we looked and saw that about 25% of the sleep apnea population will have bruxing in their history and have signs of bruxing. And then when we treated these patients with CPAP for this study, if we treated them with CPAP, there was improvement in the bruxism. And the degree of improvement directly correlated to how compliant they were with their CPAP. So those that were using it every night had a much higher degree of resolution, and compared to those that did not use it every night. But I started adding to every one of my polysomnograms that were done in the lab, I started adding extra EMG channels into the temporalis, masseter, and submental regions. So this is now part of our standard protocol that we're measuring in the sleep lab every single night when we do an in-lab sleep study. So we're getting all this extra muscle data, and we're looking at basically the external muscles of mastication. And we basically presented back first in 2008 and then 2009, basically that the missing link between sleep bruxism and sleep apnea is that the bruxing is a protective phenomena. And so let me show you that in a little more detail. So here on this sleep tracing right here on the left, you can see we have that catheter I was telling you about, and you can see the negative pressure. All right, and look at, there's a reduced amount. This person is having decreased muscle tone of the upper airway muscles, all right, of the masseter and the temporalis and submental regions. Now, look at here, there's increased muscle activity and there's less negative pressure. So this is what we're calling this tonic bruxism, not phasic. So like right here, if you go back to this slide, this event right here, that's a phasic bruxing event, because it's phasic. It is in response to the apnea. It is part of the arousal phenomena. It's not what's protective. It's the tonic bruxism that protects the patient from going into another apneic event. So you can see here's less negative pressure associated with increased muscle tone of the upper airway. Same patient, just different parts of the study. All right. So we started looking at this closer and closer. And what we found, here's another example, is that now I'm going to show you this on, well, here, yeah, okay, sorry. Okay, so I'm going to show you this in sort of a series of cases. So here you can see the decreased muscle tone, and again, here's a phasic event, and here's tonic bruxism, same patient, less muscle activity, all right? And you can see the same thing here, less, now you're looking at a longer, this is 2 minutes of data, right? So here they're bruxing, and here's the negative pressure. Now when they're not bruxing, there's more negative pressure, okay? So here you can see different series of bruxing and different levels of negative pressure. So we found that CPAP, putting someone on a CPAP can actually improve their sleep apnea, all right? So the level of evidence, what we call B, we've observed it. We haven't had a double-blind control study to demonstrate this. And what's also important to point out is not every patient will show the associate, not every sleep bruxer will show the association with the negative pressure that we're looking for. And what we're not able to measure are some of the pharyngeal muscle dilators. We're measuring the external muscles of mastication. And we don't see this on every patient, but there's enough patients that we do see this on that we know this association does exist, but we're just not able to predict necessarily which patients will or won't demonstrate the association. But I want to show you here that there's a patient, they're bruxing, and here's the negative pressure, and now they're not bruxing, and there's increased negative pressure. Same patient on CPAP. Now they can relax, and they don't have the negative pressure because CPAP is protecting their airway, right? So here, you see, and this is all the same patient. So here's without CPAP, when they're relaxing. Now they're able to relax, not as relaxed as we saw a minute ago, but they're on CPAP. They're starting to be able to let down their guard, if you will. And letting down their guard is not going to result in another apneic event. Okay. And here's another patient, basically the same kind of phenomena. So what's important to recognize, I'm going to go back to this, I made this point at the beginning, that not all sleep tests are the same. So what you're going to see depends on how you look. If you're going to use a home sleep test on a patient that bruxes and it comes back negative, it doesn't mean that they don't have airway obstruction. They may be bruxing, keeping their airway open, and the brux and the obstruction is so mild that you're not able to detect it. And some of these patients would actually have the upper airway resistance syndrome, and you may not be able to make the diagnosis unless you put in a nasal-esophageal pressure catheter to measure the airway dynamics. So it's just important to realize that these home tests that a lot of dentists are using are really good when they rule in the diagnosis, but do not use them to rule out the diagnosis. And I want you to think of a spectrum of the breathing problem with normal breathing on one end and complete obstructive breathing on the other. And there's a lot of things in between. All right. And we're finding a lot of our discussion tonight has been patients that have been in this end of the spectrum. But as they get worse and you're fragmenting sleep continuity, you're going to have the symptom, you're going to have neurologic symptoms of daytime sleepiness, fatigue. And then as it gets worse, you're going to have more cardiovascular disease and more risk of stroke and heart attack. So sleep apnea is not just a yes or no phenomena. It's not like, oh, you have sleep apnea, you're at a high risk of developing heart disease and stroke. If you're on this end, no one's really demonstrated that yet. If you're on this end, most definitely. So there's different levels of sleep apnea, and we can identify this in kids. And most of these kids are having it on this level at that point in their life. As they get older, things will get worse, and they're going to gravitate over to this end of the spectrum. But you, as a dentist, looking in the airway, can recognize subtleties, and you can diagnose it at this end of the spectrum and maybe make certain interventions to open up the airway and prevent the patient from ever getting to this side of the spectrum. All right, so I know I've said a lot, and not bad. Wow, that was like in like 25 minutes. It's a record. But I want to point out the conference. We would have had it 2 weeks ago if it wasn't for COVID. It would have been our 16th year having the Sleep Education Consortium Conference. It's going to be in Houston. It's a 3-day conference. There are physicians that are here for half the conference. It's 3 days for dentists. It's 1.5 days for physicians. But for the dentists, there's hands-on workshops, learning how to do the oral exam, learning things like the chin press maneuver, learning about dental appliances, oral appliances. How do you work with them? How do you modify them when you get the appliance? So these are some of the things that we do in this conference. And you're going to learn a lot. A lot of people that have gone this have just commented how it was extremely educational. If you want more information, the webpage is dentalsleepconference.com. And you can also just send the registration isn't really up and running. It says up and running. I just checked it beforehand. I saw a glitch, and for some reason it's not going to the registration. Send an email to info@sleepeducation.net. That email address is on the webpage. But just let us know, and once it's up and running, I'll send you an email. Make sure that you know about it to sign up for this conference. And my practice, the email for our practice, we do a lot of telemedicine. We're out there providing care to patients from other parts of the country. Sometimes the patients have to come to Houston because they just can't get the testing that they need elsewhere. But I want to work with healthcare providers from all around the country. And our website is CSMA for Comprehensive Sleep Medicine Associates.clinic. So that pretty much that's my talk. Wow, I did it in the amount of time you gave me.
Wow, you did it in New York time. Right?
There you go.
I thought you're from Houston. Wow, Ben and I were following along, no problem. I don't know.
Yeah, well,
a couple of points I just want to say, because we're getting a lot of questions on it. This is recorded, and we will send the link because there's so much valuable information and studies that people were asking about that. So go ahead, Dr. Miraglia, take it away from here.
Yeah, so it's always a pleasure to listen to you. And then, prior to COVID, I was trying to get in front of you like every year, but then whatever the conferences were, AAPMD or you name it. And the moment I saw you, it was probably about 6 or 7 years ago, the first time I was at a meeting and you were speaking. I'm watching this stuff. And instantly I was, why didn't I learn this in dental school? Like, because I see, as you're showing some of these studies and the research that's out there, I recognize the dates. Those dates predate me being in dental school. And all of this stuff was there to be taught and shown. And here I am, I come out of dental school 4 years later, and I'm misspeaking about bruxism, and I'm misspeaking about TMD, and I'm kind of heading in the wrong direction and treating symptoms versus cause. Then I get in front of you and I'm watching, and of course, this is the 50th time I've seen this, and every time it's more amazing than the previous. And then as a dentist, I remember, I'm going to ask you one of the questions I had asked, at one of the meetings I came up and said, because I'm a dentist, so I'm thinking, what's my role? Where is my impact when I think about the difference between the oral cavity and the nasal chamber? Because I've got my role in the oral cavity. Is my work in the oral cavity for a representative of a significant percentage of the issue versus the nasal chamber? In other words, could I expect a small impact working on the oral cavity or a large? And then I remember how you answered that. And that's my question now. What do you think is the difference? What is the percentage of difference between the oral cavity and the nasal cavity in making a difference, the procedures that are available?
Well, it's a real important point, important question. So the whole airway needs to be patent, and a person needs to be able to breathe without developing increased resistance. And if someone has nasal obstruction, then you have more negative pressure from there on to the rest, all the way, the rest of the airway. So you have to have a patent nose, right? So that's important. So if you're going to put someone on dental appliance, you cannot neglect the nose. Right? If you're going to open up someone orthodontically, well, by bringing the palate down, you may be opening up their nasal passages to some degree. So, but you can't neglect the nose. The thing is, if you just concentrate on the nose, only 10% of the patients, if not less, will get adequate treatment of their airway by just focusing in on the nose. So that's the problem. There's a lot of physicians will think it's just a nasal problem. I mean, if you look at some of the anatomical descriptions on like WebMD, and they're showing sleep apnea, they show someone in occlusion for both the open airway and in the obstructed airway picture, which is not the way it happens. Your jaw goes back, and all this falls back. So you can't neglect any part of the airway if you're going to treat a patient. So if the person has obstructive nose, you want to send them to the dentist, to the ENT doctor, but the opposite needs to happen. Is the ENT doc needs to understand where the dentist may play a role, and whether it be orthodontics or a dental appliance. Now mandibular advancing appliances are a great treatment, but they can also, if you're relying solely on just mandibular advancement, you may create destruction of on the TMJ or may be symptomatic. So, you want to, if you open up the nose, and maybe you don't have to extend the person as far. And I didn't get a chance to talk about CPAP in combination with dental appliances, but anyhow, in terms of what percentage, what we know is that most patients will have obstruction at more than one level. Very few, not very few, but a minority of the patients, and I can't quote you the exact number, I'll say basically 25% maybe, will have just one region. Most patients, it's going to be scattered at multiple regions, and so you really need to have a more generalized approach to resolve the problem.
Yeah, it helped me. That answer helped me years ago, in number one, having some confidence that working in the oral cavity was going to make a difference, but also in building the collaborative care, because reaching out to the ENTs to put the whole puzzle together, because like you mentioned, you do need to address the nose. It can't be left for nothing, even though we're the dentist. We have to be able to make the referral to an ENT who can then, get the nasal scope and participate in helping open up the airway. And whether that's, removing excess tissue, correcting a deviated septum, helping with the things that are from the, the nostril to the vocal cord on the inside, makes the complete picture of that collaborative care that we're talking about. But I was really relieved to hear that in working and addressing in the oral cavity gave me a significant opportunity to make a difference, in the patients. And I want to thank you for, your research and your history and everywhere you've been, and just the simple point of recognizing that the dentist plays a role in the oral cavity and how a patient breathes and sleeps. And it's been an honor to be, a colleague of yours, and to share in certain meetings where we kind of get to talk about similar topics. And then always a pleasure to bump into you. And outside of this COVID thing, this has been a whole year where I didn't really get to see you live, but we actually had lunch at the Greater New York the year ago. And we sat at a table and we were talking about the same thing again. And yeah, hopefully I didn't overstay my welcome. I have a habit of getting restraining orders from people that I admire and follow around just a little too much. But is there anything in, let's say, things to consider going forward? Like, where are we going from here? Do you want to fill in a little bit of what's coming? I know you just mentioned the meeting.
Yeah, I mean, well, there's a lot. Okay, so there's a lot going on educationally, and I'm the head of a task force that Steve Carstensen started an initiative that looked at pediatric sleep apnea and getting the American Dental Association involved and reaching out to dentists and looking at some of all these different aspects of the problem of pediatric sleep apnea. And then he wanted several task forces to be developed that would look at different parts of the problem and also solution. And I was appointed to be the head of, and I'm heading up the task force that's coming up with screening, with a screening tool that will be easy to implement, that hopefully can be used on all children, either in the dentist's office, maybe even in the school, in schools with the school nurses, just like there's hearing tests. What about just everyone going through a simple screen and then to try to identify early on these kids. So part of I'm heading up this task force, and we're collaborating with the ADA and getting hopefully to have a good consensus of a variety of specialties that are going to work together to where we're going to lead this effort to do the screening process. So that's one thing that's going on. The other is telemedicine. I hear all the time, it's like, why don't you set up your office in Seattle? Why don't you set up in Chicago? Why don't you set up, in Wisconsin? Why don't you, New York? Well, through telemedicine, I can provide my expertise to a lot of patients elsewhere. Now, the testing is a little more limited, but we can get the testing there. I give my clinical opinion, and we can move forward. But in some instances, the patients have to come out to Texas. But I've been able to have a further reach now with telemedicine, and in Texas now, there's actually part of the dental rule is that a dentist should not be treating sleep apnea unless they do it in conjunction with a physician. All right. And that is a good thing, because a lot of times, a dentist may be off there on their own doing all this stuff and dealing with a patient that has all these cardiovascular risks, and they're going to be making their appliance, and they're going to take on all this liability. And by working with a physician, you could basically, get rid of the liability. It'll be more on the physician. But then, they'll say, well, but the physician's just going to want to send them off for CPAP, or not going to. Well, you got to find the right physician. So there are other physicians like myself now through telemedicine. We're able to provide our expertise remotely and give guidance. But I think that a dentist really should not be on their own doing this management. They should be working with a physician. And there are more and more physicians that are going to be similar minded as myself, recognizing the role that a dentist can play. So the one thing I'm working on now, getting ready to launch, and we're doing it in a pilot level, is we're coming up with ways of monitoring our patients nightly through certain physiologic parameters. I don't want to go too much into it. It's exciting. We're going to be getting good data. We're getting good data. And we want it, it's not going to replace our sleep testing, but it's going to help with the management of the treatment by getting parameters on a nightly basis. And that's going to extend what we're doing from a telemedicine standpoint as well.
Yeah, that's all very exciting. And we're really happy to have you on that panel for the children, because not only are you the right person for that job, you recognize that finding the kids early can guide their growth and development into a position where they don't have to then kind of deteriorate into the OSA diagnosis. Like you were pointing out, the kids don't have to be at OSA right now. They're in the stage where it's pre-OSA, but they're going to get there. It's kind of like a slow deterioration process. One day they'll be there, but why don't we intervene now and help them with their growth and development so we don't have to have that problem later on?
Right. So then you get people like Kevin Boyd, who was going to do orthodontic interventions on 3-year-olds.
Early. The earlier the better.
Early and open up. It's easier to open up the skeletal structures. They're more malleable at that age.
If you like a wet sponge.
Right. So
kids are like a wet sponge. The earlier the better, and the quicker you move them out, the better they breathe, the better they sleep. And you're already well down the road of how the next day behavior is related to the children. And I know we're going a little sideways, but the idea is that this has so many directions to go that I think at some point, we would be happy to have you back again to continue this conversation. And I think, Lauren, do we have some time for some questions maybe? Do you have a little follow-up
Yeah, we
you want to
do.
get into?
And I already have Dr. Simmons, and you were my witness that he will come back again,
Oh,
because
wonderful.
we had literally 160 questions just on the topic of bruxism. But I think you answered a lot of them in your presentation, so thank you for that. But I'm going to just shoot off a couple of questions, and then we'll give some updates, okay? So Dr. Tinholt wants to know, can we officially tell our patients that grinding is not related to stress, or does it play a role? And if so, how?
So it does still play a role, and we can't neglect that. But is that the main driving force, statistically speaking, on most patients? I think you have to look at each patient. If a patient tells you, I'm bruxing and clenching and grinding when I'm stressed, I believe them. All right, great. Okay. Do they have TMJ? TMD? They have TMJ dysfunction? Maybe they do from all the years of grinding. Then ask the question, have you always been grinding during the day in stress? And they'll say, well, no. And then when do you think you used to grind? Frequently, the answer you're going to get is, I used to only do it at night. So what I believe is that in a lot of individuals, it starts at night. And once you start getting degeneration of the temporomandibular joint, and you get some changes in your proprioceptive feedback, then you start doing the bruxing during the day. And you may be doing it in association with stress, but it becomes a 24/7 kind of phenomena. But in a lot of patients, it started off just as a nocturnal phenomena, and it evolved over time. So you can't say what's happening now and assume that's the only part of the problem. You want to peel back and realize that it may have started years earlier just as a nocturnal problem. But there are some individuals that will just brux during the day and only when they're stressed, and they may not have sleep apnea. And some of these individuals may have malocclusion, but they may not be demonstrating obstructive breathing, and they may have no dysfunction of daytime focus or concentration. But that, I think, is more the exception, not the rule.
At what age do you first see bruxism? Recommend treating it? And do you see symptoms in babies in bruxism prior to tooth eruption?
I don't examine babies at that age enough to be able to answer that question, but we do see it in kids. The one study I showed you was on kids with getting their tonsils and adenoids removed, and how it improved bruxism. So there's no age that is protected from sleep bruxism. I think tongue thrusting is another phenomena. I also think that finger sucking, thumb sucking, those are all maneuvers that help keep the mandible in a more forward position and can be soothing for an individual, a child who's otherwise having more difficulty in their sleep and maybe more restless in their sleep, and they're going to have more settling by doing maneuvers that they've adapted and learned subconsciously that are going to help open up the airway. But then once they do that, then you're going to get all of the other orthodontic changes by the sucking in the thumb and all the tongue thrusting, And what about the kid that has braces? They get the braces off, and a year later they need to get braces back on. Why? Because now their teeth are spreading apart. Why? Because they're thrusting their tongue. And one thing I really think is a problem, and really, it's a question I'm just going to mention now. Pulling adult teeth in a child is something that blows my mind. You don't want to pull, it's just not about the teeth, it's about the airway, it's about the skeletal structure. So you need to make room for the teeth. That crowding is a sign of the crowding of the airway. So you don't just pull the teeth.
Applause here.
Yeah, because you got the tongue.
Our listeners, for sure.
Yeah, amen to that.
Yes.
You got to bring things forward and open things up. So bruxing, though, it can occur at any age that I've seen, but the infant, the toddlers that you're describing, I don't see enough of them to know if at, let's say, before 2 years of age, how much of bruxing is going on at that age.
At what age do you believe we should be screening children for airway obstructions?
Well, I think we should be more aware so that there's no age in which we should be naive. But to go through a formal screening thing that we're talking about, probably at about 2 to 3 years old.
Do night guards make sleep apnea worse?
They can. Okay, the night guards, that's a big topic.
Yeah, let's touch on that.
3 minutes.
That'll take 20 questions.
Okay, wait. So you're saying a non-airway dental appliance. So not a mandibular advancing appliance, not a tongue retainer, but a bruxing appliance, something that's going to, NTI or some other kind of, thing that's going to protect the enamel and open up the joints so they're to decrease the pain and prevent the destruction. Those can, in many patients, make the airway worse. They're not bringing the mandible can still slide back, and there have been studies that show that the airways can be more obstructed in patients that are wearing appliances, a bruxing appliance. So it's not across the board universal, but it can happen. Yes.
Great. And how do we as dentists treat bruxism in kids?
But looking for airway obstruction, right? And get at the source. What I'm trying to point out here is that the source is a negative pressure in the airway, and the body having maneuvers to try to resolve that challenge or that stressor. Right? So is it due to stress? Yeah. What kind of stress? Airway stress from negative pressure because of anatomical deficiencies. So the best way to treat it is to overcome those deficiencies and not to be afraid of using something like CPAP as a temporizing measure. I don't want to put a kid on CPAP for the rest of their life. I want to put them on it just to get them to be more awake during the day and to resolve the underlying problems that they're having while they're going through some other long-term management therapies such as orthodontics or surgery.
Do you see any relationship between iron levels and bruxism?
Not directly, but iron levels are known to be associated with restless leg syndrome and the phenomena of periodic leg movements of sleep. So then the real question is, well, could the arousals from the periodic leg movements of sleep be causing a bruxing phenomena? Well, in the patients that I've seen that occur, that association to be present are individuals that also have obstructive breathing. And what I've seen in some instances, sort of interesting, is that it's almost like the individual gets conditioned that an arousal will include the bruxing phenomena as part of that arousal. And it may be that obstructive breathing is frequently causing the arousal, and the bruxing clears the airway. Okay, but then there's almost like a crossover. So it's almost like any kind of arousal can trigger that same kind of bruxing phenomena, such as a leg movement. Right. So I've never seen it in an individual or a child that had periodic leg movement sleep that didn't also have obstructive breathing. What I've also seen is patients, when we're treating the obstructive breathing, there may still be some residual bruxing as part of the arousal from the leg movement. And I think what it is it takes a while to desensitize that reflex. So, there's a conditioned phenomena that if something's disrupting sleep, wake up and brux. And so, again, we're talking about the phasic bruxing, not the tonic. Tonic bruxing is, I started answering your question, I didn't categorize it, but phasic bruxing, could it be related to the periodic leg movements of sleep? Like I said, probably not in a patient that doesn't also have airway obstruction. I can't say that for sure. I don't know that anyone studied it. But the question was really more specific on iron levels. And if iron is going to play a role, it's because of how it is associated with periodic leg movements of sleep, which is a sleep disorder.
What are your thoughts on a high-res pulse ox as a screening tool?
It has a role. So basically, you're doing high-resolution pulse ox. So what does high-resolution pulse ox mean? Well, you're sampling it at a very high rate rather than once per second. So you can get heart rate variability. You're basically getting heart rate rhythm changes with that high frequency or the high-resolution pulse oximetry. It's not a matter of, you're desaturating a 0.25% or, the oximeters have a certain degree of air. Movement itself is going to cause some fluctuation, and it's not all about desaturation. So if you're going to use a tool, understand what you're getting from the tool, and you're going to get heart rate variability from it. And so it's useful. And is it going to be replacing a sleep study? No. Can you use it for disease state management? Maybe. But is it useful to do? It could be useful to do. Don't be a maverick out on your own, out there just doing it on your patients and giving them medical diagnoses and not getting the physician involved. But you got to find the right physician that's going to have an open mind to understand what you're really doing.
And will bruxism cease once airway is improved?
Depends on the individual. If the bruxing in most individuals, we're finding that to be the case. Ron Preen would be much better to answer that question than me. He is an oral facial pain specialist. He saw in his practice how the bruxing improved by treating the airway, to the point that he basically, every one of his patients, he would screen at least through a good history to find, is there airway obstruction? And he would send me these patients, and we were looking for airway obstruction. So he would find that if he didn't address the airway, he could not get resolution of the bruxing. He may get rid of the TMD because he's put the person in a splint, and they've taken some of the pressure off the joint itself, but he's not stopping the bruxing process. These individuals are bruxing into their appliance.
And can you just touch upon Gerd and bruxism? What's the correlation?
Well, I already told you, negative pressure, right? The negative pressure is not just in the back of your throat, it's in your chest. So your whole chest is like a vacuum chamber, all right? And that means if you've got slight incompetence of your lower esophageal sphincter, some of the gastric juices will get sucked up from your stomach into your esophagus in association with the negative pressure from the obstructive breathing. So back in the 90s, when I was at UCLA, I actually did a study where I took patients that had nocturnal Gerd, and we did sleep studies on them, and we put the nasopharyngeal pressure on them. When we titrated their CPAP, we didn't stop the titration process. Once we got rid of their desaturation or their apneas, we continued to titrate until we got rid of the negative pressure. All of those patients had resolution of the nocturnal Gerd.
Okay, I think we have time for one more question. Tongue tie and bruxism, what are your thoughts? Everyone I see who has a tight frenum presents with clenching patterns.
Okay, well, it's interesting. So, if you don't have the proper mobility of the tongue, and so if there's restriction from the frenulum not being, if it's causing the restriction, then that may also lead into airway obstruction. And so that, again, in kids, I can't say that I've really looked specifically. It makes sense that there is that association, that there's going to be bruxing. What would be interesting to find out is the relationship between daytime bruxing in those individuals versus nighttime. And if there's a restriction, are they needing to brux during the day because of the restriction? I'm going to guess not. Why? Because the restriction isn't leading to airway compromise during the day. So when they're asleep and their mandible goes back, and now the tongue is going to go back more because of the restriction, and they're going to brux to clear the airway. I don't know that for sure in relationship to those that have a restricted frenulum, but that's my guess.
I'm going to say the final question for Dr. Miraglia. I don't know. I know, Doug, Ben, you've been waiting so long for this interview. Is there anything that you wanted to ask that you feel would be a good way to close this out? And we'll give some updates in a moment.
Oh, the questions are endless because
Yeah.
Dr. Simmons is such a wealth of knowledge. I think the best thing to do is to have him back for another session, because there's so much more to talk about and share. And he has decades of, tonight we got a clip of some of the research that was done as many as 2 and 3 decades ago. And so I think we set up another meeting and we can cover another 30 minutes with him and a few more research articles, and just keep touching the subject, because it helps a lot to be able to look at the patients a certain way and then offer them solutions when you're working on the cause versus just the symptoms. And so I think we could build this to be a bigger type of meeting rather than just 1 hour. 1 hour is nice, but we need more of Dr. Simmons.
Yeah, Dr. Simmons, what are you doing every Monday?
Same time next week.
Okay. Well, thank you for the opportunity. It's a pleasure for me. And like I tell people, the knowledge does no good if it just stays in my head.
Well, and we certainly appreciate it. And everyone is chatting up a storm here and thanking you. This is wonderful information. So I'm just going to go ahead and share my screen with a couple of updates, both from Airway Health Solutions as well as you, Dr. Simmons, so people can know exactly where to find you. So let me go ahead and do that quickly. So we love these Airway Health Solution conversations. We really feel like it brings the kind of, it closes the gap and it puts the pieces together. So next week, we're actually having Brittany Sierra and Carice Laguerre, as well as Dr. Miraglia and myself, are co-hosting again on integrating myofunctional therapy into the dental practice. So that'll be an exciting, exciting conversation. Then timely, we're going to have Dr. Miraglia back in 2 weeks for early interceptive ortho. So a lot of the questions that were asked today can perhaps be addressed as well then. Then we're having Dr. Scott Siegel on March 10th, focusing on infants and pediatrics with tethered oral tissues. Kevin Ohlendorf is going to come on and share with you his tips and tricks of the industry knowledge, just working with airway expansion appliances. And then we're excited to have in Q2, Dr. Michael Gelb, who'll be talking about acute TMD and how to treat the acute patient, as well as Dr. Lauren Ballinger, who is strictly just an airway pediatrician who focuses solely on airway health. We are busy at Airway Health Solutions. We're trying to really there's so much information to bring, and we're bringing it as quickly as we can. So we're also listening to your requests, where we just made last week a clear aligner case review course with Dr. Ben Miraglia. It's going to be March 25th. It's 3 hours, so it's one-on-one interaction. We're launching our myofunctional therapy course, which we'll talk about next week. So that's going to be in conjunction with our mini residency on March 19th and 26th. And coming soon, we're going to have a course on clear aligner therapy and the TMD patient. So exciting stuff. And if you're really interested in learning more about becoming an airway dentist, we have the 2-day mini residency. Many of you know about it. Please feel free to visit our website for more information, as well as testimonials. And they'll go over exactly what we cover in the 2 days. Day 1 is pediatrics, and then day 2 is adult dentition, focusing on expansion and interceptive orthodontics. So there's certainly a need for airway dentists. We just created an airway dentist locator. So we are very excited to see all these green dots. We have one coming up in Canada as well, but we certainly need more. So patients are reaching out to us, asking us where they can go for their airway dentist. So once you take our mini residency, we do put you on this map to say that you are airway, that you're trained with Airway Health Solutions. So that's another exciting aspect. Please follow us on social media so you can see these upcoming events, the links as well. We're on Facebook, Instagram, and YouTube, as well as my blog. I'm going through expansion myself, so check that out. It's very patient friendly. And you can contact me at either info@airwayhealthsolutions.com, visit our website, and then here's Dr. Jerald Simmons. His info is wonderful. Take a picture of this, go to his website for the telemedicine services. He can help you. You know, you don't have him in your backyard, but he does do telemedicine services. Dr. Simmons, is there anything else you wanted to add about this service that you provide?
Well, we, are here to help. I mean, we've had patients that have, we've interacted with dentists that have been in Seattle, California, New York, just a number of other places, and it's sort of surprising, not surprising any longer, but it's disappointing, I guess, sometimes how difficult it is for a patient to arrive at their diagnosis. And there'll be a dentist who is more educated on this topic than the physicians in their community. And I'm sure it's very frustrating for the dentists. And if they didn't have someone like me out there saying, yes, you're right, they probably, after a while, really second guess themselves and just find themselves professionally frustrated because there's nowhere to turn. So you can turn to us, and we'll do our best to help.
Well, we're glad you're here. And then here's the Sleep Dental Conference. There was a question about, can non-physicians or non-dentists attend?
Yes.
Okay, so the more the merrier, and the more collaboration, the better, right? That's the bottom line, for sure. So that ends our session tonight. This was really, really an amazing session. Thank you so much, Dr. Simmons. Thank you, Dr. Miraglia, both for your wisdom and for your quest and your crusadership to make the world healthier and to provide airway health for everyone, starting from age 0 all the way up to 99. So we thank you, everyone. Thank you for joining us. I'm sorry if we didn't get to answer all your questions, but we will have Dr. Simmons back. And until next time, have a wonderful evening.
Great.
Good night,
Thank you.
everyone.
Take care. Bye.
Thank you, Dr. Simmons. Take care. Thank you.